Hello, my name is Rachel Leong, and this is my case study on gastric bypass-related hyperammonemia. Starting off with the background, with bariatric surgery, its goal is to reduce the risk of health problems associated with severe obesity. In 2020, the incidence was around 198,000, and common complications that come with a Roux-en-Y gastric bypass include small bowel complications and obstruction, dumping syndrome, nutritional derangements, and rare neurological manifestations. This brings me to hyperammonemia, which is a metabolic condition with a toxic accumulation of ammonia in the blood. A normal reference range level of ammonia is typically less than 50 in adults. So together, that encompasses gastric bypass-related hyperammonemia, or GABA. There are only 10 to 15 published cases currently. It is an under-recognized and treatable complication with rapid decompensation and poor outcomes, including a high fatality rate of around 50%. In terms of its clinical profile, this typically occurs in middle-aged, female predominant with no history of liver disease. Its clinical presentation is variable post-surgical time course with successful weight loss post-Roux-en-Y. Lab hallmarks include an elevated ammonia level, nutritional and essential amino acid deficiencies, as well as a low zinc. The exact underlying mechanism isn't clear. However, potential mechanisms include a mass urea cycle defect, high nitrogen load from rapid weight loss, reduction in nutrition intake resulting in catabolism, leading to protein breakdown in extrahepatic tissues, gut microbiome alterations leading to increased portal system recirculation of ammonia. The purpose of this presentation is to raise awareness of GABA and provide additional knowledge. That brings us to our case presentation of a 41-year-old female who presented to the emergency department with complaints of abdominal pain along with acute encephalopathy-related symptoms, including lethargy, confusion, and trouble speaking. She had a height of 167.6 centimeters and weight of 67.3 kilos. This is a BMI of 23.9. Past medical history include a Roux-en-Y gastric bypass around 16 years ago, and she has lost around 200 pounds post-op. She was also diagnosed with non-alcoholic steatohepatitis, or NASH, hypertension, hyperlipidemia, May-Turner syndrome, and deep vein thrombosis. In terms of significant lab findings, she presented with a low glucose, a slightly elevated ammonia of 53, a low copper level of 33.3, a low selenium of 20.4, a low zinc level of 35.5, a low vitamin A of 0.11, and a slightly low vitamin C of 22. On the right-hand graph, you can see her ammonia levels trended throughout her hospital admission. In terms of her clinical course, an abdomen and pelvis CT on admission showed severe diffuse hepatic steatosis. In terms of the goals of treatment while she was in the ICU, it was to reverse and improve her encephalopathy, lower the ammonia level, and her treatment included lactulose, rifaximin, vitamin/micronutrient supplementation, and parenteral nutrition. The patient's encephalopathy and hyperammonemia improved, and she was discharged home with rifaximin and zinc. For our discussion, this patient case demonstrated the potential for the occurrence of GABA in patients with a history of Roux-en-Y. It remains unclear how gastric bypass surgeries cause hyperammonemia. However, several mechanisms have been hypothesized. For the management of GABA in this patient's case, lactulose, rifaximin, repletion of micronutrients, initiation of nutrition, and reduction of protein intake likely help to resolve the patient's hyperammonemia. When prescribing parenteral nutrition, an important component is the titration of amino acids in these cases. With ammonia levels greater than 100, the EUH nutrition support team adopted the practice of not providing protein until the level is less than 80. From there, a slow titration is done in order to reach the patient's protein goal as the ammonia levels decrease. While this patient survived, it is crucial to remember that this is not always the case due to its high fatality rate. As this case suggests, early recognition of GABA was crucial for proper diagnosis and early intervention, leading to improved patient outcomes. Below are my references. Thank you so much.